This program is brought to you by Emory University.
Good morning, everyone. Thanks for being here. I figured we'd have sort of a skeleton crew on this holiday week. Our speaker this morning is Jeong Kim. Hwan is a third-year fellow in the research track doing his first clinical year. He did his medical school at University of Chicago, did his residency here at Emory, did 2 years of research with Dr. Kayumi mainly and Dr. Sperling some as well. And as you can see, is going to talk to us about social determinants of healthcare for cardiovascular disease. Hwan.
Thank you. Good morning, everyone, and Happy New Year. Today, I'm going to discuss social determinants of health for cardiovascular disease. I do not have any disclosures. So we're going to start with the case. So this is kind of a unique way of driving a story. So we're going to have two patients, but coming with the same scenario. 55-year-old gentleman with a history of hypertension, hyperlipidemia, tobacco use, and obesity who presented to the emergency room with a chest pain. And with the appropriate workup in the hospital, including the emergency room and cath lab, we found out he had NSTEMI and showed a mid-LAD culprit lesion, ended up getting a PCI with a drug-eluting stent. After that, patient was initiated on aspirin, Plavix, high-intensity statin, beta blocker, also started on hydrochlorothiazide and ACE inhibitors for additional blood pressure control. Prior to him going home, we counseled extensively on his medication use and lifestyle modification, as well as the 2-week post-discharge follow-up. And now 2 weeks pass. And now patient A comes in. He comes in and saying he's complaining with the medications. He's very curious about the blood pressure readings he's been getting at home, which are above the goal. He's gone online and read about obesity and heart disease. He's interested in the exercise regimen he read about. He admits that he's very worried about having another heart attack in the future, but he has not smoked at all since the discharge from the hospital last time. Same scenario, but patient B. He misses the 2-week appointment due to his work schedule. After outreach from the clinic, he ended up coming to another appointment 2 weeks later, and he's very concerned about taking so many medications. He's only taking aspirin and blood pressure medication, only if he has a headache. He's concerned about statin side effects. He saw a TV commercial, so he stopped taking statin. Everyone around smokes, so it's hard for him to actually stop smoking. So what are we clinicians, cardiologists are thinking just with these two patients? Patient A, he's appropriately concerned about his recent MI. He's adherent to the medication that we prescribed, and he already quit smoking. He made a good effort to learn about his condition. He has begun already to make some needed lifestyle changes. On the other hand, patient B, his blood pressure is still uncontrolled. He has missed the appointment already. He's not taking most of the prescribed therapies that we prescribed prior to discharge. So I want to point out we encounter this kind of scenarios a lot in the clinic. We do all the workup appropriately in the hospital, and then we prescribe all the guideline-directed therapy. But a lot of the trajectory from the patient's outcomes and health and risk in the future really depend more than just what we do. These two patients came with a similar clinical presentations. However, within already 2 to 4 weeks, we can already see that the trajectories are vastly different. So today I want to discuss the definition of the social determinants of health and importance for the cardiovascular disease, and also discuss some different categories of social determinants of health in relation to cardiovascular disease. And toward the end, I want to discuss the current understanding of the mechanisms by which social determinants of health affect cardiovascular disease. So according to WHO, the social determinants of health is defined as conditions in which people are born, grow, live, work, and age. As you can see in the picture on the right side, is a multifactorial concept. These circumstances are shaped by the really large forces, distribution of money, power, resources at global, national, and local levels. And we believe that this is largely responsible in the current era for the health inequities, the unfair and avoidable differences in the health status between individuals, both within and between countries. we hear about this term, this is very used a lot these days in the press and the research, as well as in the, just people know about this more so than before. There are a lot of things that we can think of when we think about social determinants of health, such as income, education, going into race, gender, even physical environment, as well as social environment. So why is this important? So this is the recent statistics from the AHA from 2019. This is a pictorial representation of the CV mortality across the time span of past almost 80 years in the United States. The CV mortality has been on a steady decline since the 70s. We believe this is due to advancement in prevention and treatment of cardiovascular disease and cardiology. However, still is the leading cause of the death in the United States, accounting for 1 in 3 that's happening in today's world. And if you can see toward the end, actually, there's a slight plateauing or uptake in the cardiovascular mortality in the recent years, in contrast to the overall steady decline. If you look more closely into the subgroups of the population, on the left-hand side, this is the similar graph that we saw earlier, but now stratified by race. Now there you can see that the black people, compared to the white Americans, have greater mortality from cardiovascular disease, and that gap seems to persist over time despite the overall decline in reduction in mortality of the overall population. On the right-hand side, this is the cardiovascular mortality by counties in the United States, and you can see that there is a quite strikingly vast difference in the mortality rates depending on geographic locations of this country. So we are finding that the benefits of advancement in the prevention and treatment is not shared equally by everyone or every region of the country. And overall population health cannot improve when parts of the population do not benefit from the improvement in prevention and treatment. And we believe that the most significant opportunities in the modern era is to improve cardiovascular outcomes in the country, probably lies within addressing the social determinants of health. With that importance, AHA recently released a scientific statement in 2015 reviewing the literature that's available so far, as well as addressing the need for further research and then increased awareness. More recently, in 2019, when the primary prevention guideline was published, one of the 3 main overarching recommendations in regards to patient-centered approaches to primary prevention was to consider social determinants of health in terms of choosing the ideal therapy for preventing ASCVD. So there, as you can see, that the domains of social determinants of health are very multifactorial and is intertwined. To catalog into different boxes is only artificial. So there's no agreement about what goes into what and what are the correct categorization of the social determinants of health. But I do want to go over some of the kind of key social determinants of health for cardiovascular disease for the next part of the talk. This is the boxes that I have found to be useful. I'll be spending most of the time on the socioeconomic status as well as the environment, because the race and sex or gender are a relatively big topic on and of itself that probably needs more attention than sweeping over the evidence. So starting with the socioeconomic status, income is a big part of it, as we can all know. This is kind of one of the older population cohort from N. Haynes in the United States. Recruited people from 1983 to 1988 to 1994, about 1,200,000 people looking at the death index for the next 13 years. And they collected the family income for 12 months prior to the baseline survey. And they looked for the CV mortality in this analyses and adjusted for demographic covariates in the analyses. You can see on the graphics on the right, this is for women. On the x-axis, the household income. Y-axis, the hazard ratio. The 1 being the average of the population. And the 6,270 is the poverty line in the $1991 at the time. And then 20,190 is the equalized median income in 1991 dollars. You can see there's a clear negative correlation between the hazard of CV mortality and then the household income. And again, very similar graph is seen with the men as well. Another big cohort from the United States, from ERIC, atherosclerosis risk in communities. This is a more recent cohort that was established in 1987. About same size, 13,000. This recruited from 4 different regions of the United States. A little bit older than the NHANES in terms of criteria. What they did, they also did the same thing, but they divided into 3 different groups: low, medium, high. And in terms of the follow-up events, they not only looked at the CV mortality, they divided into more of a non-fatal MI, non-sudden cardiac death, and sudden cardiac death. On top portion is the men, bottom portion is the women. And you can see there is, again, the negative correlation between the household income and the CV mortality or CV outcomes in this era as well, in this model as well. Finally, for income, I want to point out the international study. This is a multinational meta-analysis looking at acute MI. There's quite a bit of 19 studies here, ranging from studies from the 60s to 2000s. And then overall, people who were in the lowest income categories of the study compared to the highest income categories had about 71% higher risk of having acute MI in the follow-up. So second portion of the socioeconomic status is education. Again from Eric, similar analyses, same criteria, but they now looked into the highest achievement of education from grade school to professional school or graduate school. They followed through 2013 and looking at more broad endpoints, including coronary heart disease endpoint, including death, MI, revascularization, and heart failure, stroke. This is the kind of unusual but is meaningful way of putting out the cumulative incidence or survival curve. This is the age of patients. So they're plotting the risk of CV events at that age of the person, because people are coming in different age at baseline, and they also need to account for a competing risk of non-CV death. You can see people who had only grade school had a 55% of having a lifetime event in CV outcomes, whereas the people who've graduated from the graduate school or professional school only at 36%, so about 19% difference in the risk of having these adverse events. Another interesting tweak in their analyses, they stratified that people into both by household income and education, and they found that education and income were independent and additive, meaning that higher education is always better independent of income, higher income was always better independent of education. I want to also shine some the light on our data from Emory. This is done by Hevel Kelly and Anurag Veda. This is looking at Emory Biobank patients. These are people who are recruited from Cath Lab here, about 6,300 people. These are heavily diseased, already established patients who are suspected to have or have a significant coronary artery disease or heart disease. And we see the same analyses looking at CV death and MI divided by the highest attainment level of the education. People who had the lowest education tend to have suffer from more burden of the CV outcomes. There is a more recent study, another different angle to look at this problem. So people may ask, is this causal relationship? It's hard to do experiment or randomized trials on this kind of data, but recently with the advance of genomics and the Mendelian randomized analyses, you can try to get at that more possibly. So basically what they did was they looked for SNPs associated with the education in the large GWAS, genome-wide association study. Then they, before that, sorry, so they did regular analyses. They found that the increase in education duration by 1 standard deviation was associated with the 30% reduction in the prevalence of disease, and then probably 20% reduction in the incidence of disease. And then did GWAS to look for SNPs, genetic markers that are associated with education, and they used those markers to see would show the people who have how many numbers of these genetic markers have further outcomes of CHD. Basically trying to see if we can randomize because SNPs are not affected by our social influence. So this is trying to get at the randomization as much as possible. And then the result was that, again, similar magnitude effect was seen with the 1 standard deviation increase in the education duration. The conventional Mendelian randomization showed about 30% or 40% reduction in the cardiovascular events, and further sensitivity analysis using more sophisticated models showed about the same effect size. Final pillar of the socioeconomic status is employment. So this is an old study from London from the 70s, looking at 17,000 people. They're male civil servants. So they have all office-based jobs, so not thought to be economically disadvantaged. They categorize jobs in these categories. It's kind of archaic in my mind. It doesn't really make sense what's more desired, less hard. But according to their definition, the administrative is the highest occupation grade. As you go to the professional, clerical, and other, which is more manual labor or repetitive manual labor, was the least desired occupation. And this is the cross-sectional data. As you go from the more higher grade to the lower grade of occupation, you can see changes in the systolic blood pressures gets higher. You can see the smoking prevalence gets higher, weight gets higher, physical activity gets to lower. And then not only that, when you look at the overall 10-year mortality across the spectrum of the different age groups, the increase in the mortality was seen with the lower occupational grade of the categories. How about the U.S. data? This is the data from the U.S. From the health and retirement study with age above 50, about the same size, and they were looking at the acute MI instance. On the most left-hand side, people who are employed tend to have a lower instance of acute MI. This is stratified by the number of times that you lose job. So the more times you lose job, you're at higher risk of having acute MI. And this is actually interesting. This is how long of time you've been unemployed. And this is what is hard to see, but this was showing is that in reference to zero, the people who just lost job within a year, in the last year, had the highest risk of having acute MI. And this is adjusted analysis showing a different way with covariate adjustment to see if the effect side, the association remains significant, and it is. And the interesting thing is we just saw that people who lost a job within a year compared to this 2 to 4 years or 5 or greater, they had the highest increased risk of acute MI. I also do want to point out the fact that there was difference between unemployment versus retirement. Both do not work. However, there seems to be the difference in the risk of acute MI did not seem to be significantly associated with the retired people, whereas the unemployed people did have significant increase in risk. So it seems to be that the actual job loss, not the retirement, seems to be associated with the increase in risk of acute MI. So in summary, there's no single parameter. However, we find that income, education, and employment are one of the known factors of socioeconomic status that's been associated with cardiovascular outcomes in the literature. Again, as I said, I'm going to just briefly talk about race and sex because they're very important topics in talking about disparities and inequities of cardiovascular health. So I'm going to just point out some salient points that I think we should not forget and remember as we talk about this. So U.S. population is projected to become more and more diverse in the future compared to 2008, whereas the majority of the population were white. By 2050, that the majority of, they're not going to be a majority anymore, and there's going to be a huge increase in the proportion of the Hispanics and non-white population. This is a very similar graph that I showed earlier. Again, despite overall decline in the reduction of the cardiovascular mortality in this nation, the Black people seems to have suffered from the greatest burden of the disease, regardless of that overall improvement. And we probably encounter this in the clinical setting too. The African Americans, Black Americans tend to have higher prevalence of hypertension, and Hispanics and then Black Americans also do have higher prevalence of obesity and as well as diabetes, which are becoming more and more a problem for us now. This is data looking at people in the Medicare data, about 1.2 million people with acute MI coming in between 2000 and 2005. And they were looking at whether Black people compared to non-Black or white people had a difference in the rates of coronary revascularization. And they found that by 30 days, the percentage of revascularization was significantly lower for Black Americans compared to white Americans, despite after significant multivariable adjustment. Moving on to the sex and gender, again, this is a huge topic. I just want to point out that this is one of the leading causes still for women. Significant disparities that we already know exist with these risk factors, this treatment and outcome based on sex. Women tend to receive less intensive treatment for CV risk factors and less likely to reach the targets of the treatment, for example, blood pressure or lipid-lowering therapy, and they're less likely to undergo invasive procedures, and they tend to have delayed balloon times as well. And then if you look at the recent clinical trials, although it's getting better, the overall representation of women are not as good as men. Just before I move on, this one example. This is a cardiac rehab referral, looking at 19 observational studies, about 240,000 people, and the 40% or so was the women. And if you look at that, the being women is a risk factor for not being referred to a cardiac rehab after appropriate indication. About 30%, 40%, and 30% reduction in odds of being referred to cardiac rehab. So for the next half, I want to talk about environment. This is a little bit different focus. I showed this graph earlier, so there is just a stark difference in terms of the CV outcomes in the nation, depending on where you are. So over the past 20 years, there's been a major paradigm shift in thinking about cardiovascular epidemiology from individual to overall context. In the older era of studying these, for example, Framingham risk scores, we were thinking about individual and then what they do and then what are the risk factors for that individual and how that relates to cardiovascular disease and how to prevent that by developing therapies. Now, for the past 20 years, there's been increasing amount of research looking at not only individuals, but social context, as well as the physical environment and how that affects cardiovascular health, and how that plays a role in determining someone's cardiovascular health and outcomes. Probably the most landmark study in this area was published in 2001 by Dr. Anna Diaz-Rue. She's one of the most prolific researcher in this field. This was published in the New England Journal looking at the neighborhood residence and incidence of coronary heart disease. This used the data from ERIC, which I introduced earlier, used about 1,600,000 people. They were recruited at baseline from 87 to 89. And what they did, they linked their residential address to census block groups. This is a much smaller unit than, for example, zip code or census tract. The average number of people in the census block is about 1,000 people. And what they did is that for each census block groups, they collected different indices of their area socioeconomic status, not individual. So median household incomes, median value of houses, percent of houses that are receiving interest, dividends, or net plus income. Education, not individual, but how many people in the area have graduated high school or college. Occupation, how many people in the area have employed in the executive, managerial, or professional occupations. And they also collected individual data too, individual income and occupation, and traditional CV risk factors, and they were following up these people for about 9.1 years with the coronary events defined by MI or coronary death. I'm gonna walk through the table. This is the all white people. The majority of the population were white. I think about 70% or so were white. that, with the the higher socioeconomic status of the neighborhood, there was, with the lower socioeconomic status of the neighborhood, there was increased risk of coronary events, almost up to 1.6 after all the multivariable adjustment. And that was true for blacks, but the effect size was a bit smaller, and the p-value became smaller. Sorry. Another take on this data was that they also examined the same analyses across the spectrum of the personal income, because we already know that personal income is a determinant of cardiovascular outcomes. So how does that play? And across the income spectrum of the individuals, the neighborhood socioeconomic status were still meaningful in determining the cardiovascular outcomes, meaning that regardless of how much your income is, that the neighborhood area socioeconomic status was negatively correlated with the cardiovascular events, and both in whites and black people. So that was a big paper. And after that, a lot of subsequent papers followed to show similar analyses looking at different endpoints, different cohorts, different countries, so that for the past 20 years, that's been going on. We do also want to share some Emory data done by Medtopol about a year ago, looking at cath lab patients, about 3,600 people. We did the same analyses. Basically, we put people into their residential address by their census tracts, and we calculate their neighborhood socioeconomic status scores based on the same indices that I introduced earlier, and they were followed for up to 3.3 years. And you can see the same people, the people we take care of. There is an increase in the instance of the all-cause mortality or CV mortality over MI for people who are living in socioeconomically disadvantaged neighborhoods compared to the people who are living in more advantaged neighborhoods from the socioeconomic perspective. Final tweak on this is that so looking at the procedures. This is data looking at about 800,000 people from different regions of the country. They were quartiling or dividing into the groups of people with the quartiles of the area income based on their zip code. And they were looking at, does that matter in terms of what procedures you get, what kind of procedures you get when you come into a cath lab? They found that the over angiogram was less likely to happen if you're coming from the lower income area. The revascularization tend to happen less often when you're coming from low income area. And if PCI, the drug-eluting stent was less often used for low income area hospitals. And what they were looking at the STEMI subpopulation, people who are coming from the lower income area tend to have increased mortality. And even after adjusting for PCI use, that the association remains significant as well. So that was big shift. And now the next question was that, what about beyond neighborhood socioeconomic status? What are the features of neighborhoods that are important in determining or influencing the cardiovascular health and disease outcomes? And then more and more research more recently seems to focus on that kind of specific aspects of the neighborhood that are determinants of the cardiovascular outcomes. So some examples are physical environment and social environment. So I'm going to go through them a little bit. So this era of research mostly done in MESA. There was a landmark kind of cohort that looked into this kind of in depth. So MESA is a large cohort, population-based from 6 different sites of the United States. They used the baseline cohort, which is about 6,800 people recruited from early 2000. They had an ancillary study. They asked people what they think about their neighborhoods, including food access, walkability, physical environment, and they were able to aggregate those numbers to kind of assign different scores of all these features to the given neighborhoods in the MESA cohort. And this is looking at the incident obesity. So just looking at people without obesity at baseline, about 4,000 people, and they examined whether the walkability and the healthy food access in the area is determinants of incident obesity when they follow up, defined by as a BMI greater than 30. And you can see on the left-hand side, which is the walking environment, The darker is the better, the lighter, the worse. And in both in women, there's overall negative trend in instance of obesity, and then for healthy food access, that association seems to be even more clear, meaning that healthier food neighbor with the more desirable health food access seems to have a lower incidence of obesity when they follow up in 5 years. Very similar analysis looking at incident diabetes. About 2,200 people without baseline diabetes. They did the same analyses, and they found that when they account for both physical activity and healthy food access, that people who are living in healthier neighborhoods with the more physical activity research as well as healthy food tended to have a lower instance of the diabetes when they follow up in 5 years. So not just now the next is not just focusing on the diabetes or obesity. Can we look at the overall cardiovascular health? There's this metric called Lysimple-7 or cardiovascular health score that's promoted by AHA, trying to encompass 7 different domains of modifiable cardiovascular risk factors to assess the overall cardiovascular health of any person, including patients or healthy people. And total scores can be divided into poor, intermediate, and ideal. The cutoff is not concrete, but different studies have looked into different cutoffs. This is the kind of later study from the MESA, large study looking at the more diverse attributes of the neighborhood, including the favorable food access, healthy food availability, physical activity, and social cohesion, safety, and the neighborhood socioeconomic status. And they were looking at the prevalence of people who had ideal cardiovascular health scores, Lysimple-7 scores. And as you can see, overall, there's very clear linear trend in the prevalence of the ideal cardiovascular health if you live in more healthier or more desirable neighborhoods based on these characteristics. So that seems to focus more on the physical environment of neighborhood, but even more recently, that now there seems to be a focus and interest in studying what about the social environment of the neighborhoods, right? In terms of bonds between residents and the activity that's going on in the neighborhoods and the community exercise and things like that. Do that actually matter? This is a study from I think there was a health and retirement study looking at 5,000 people. And this was looking at social cohesion. Social cohesion is like a kind of thing in terms of how much you feel like you are sharing value with the neighbors, and how much you trust your neighbors, and how much you think you are belong to your neighbors, things like that, in terms of kind of sense of cohesion between the residents of the particular area. They found out that, and during the 4-year follow-up and looking at the acute MI, people who had reported a better social cohesion tend to have a lower risk of acute MI in this cohort. Again, so there's a similar study going on with the Emory, also actually in collaboration with Morehouse. This is looking at the Black Americans specifically. This was a study of people who are living in Atlanta, Georgia, without known cardiovascular disease. And then we assessed the Lysimple-7 scores and also did the same assessment of neighborhood. We asked about their aesthetic quality, walking environment, safety and food access, and social cohesion, connected with neighbors and violence. And we found very similar association that was seen in the MESA, meaning that there seemed to be somewhat of a linear association between the all these features of the neighborhood and the prevalence of the ideal cardiovascular health. And interestingly, there was a very strong trend, a relationship between the social cohesion and activity with neighbors compared to more physical environment of the neighborhood features in reference to the ideal cardiovascular health. And that association was even after multivariate adjustment that social cohesion and activity with neighbors were significantly associated with the increased odds of having ideal cardiovascular health in those populations. So in summary, the residential environment characterized by socioeconomic resources, walking environment, or access to healthy food have been shown to be associated with cardiovascular disease. And then social environment is increasingly recognized an important contributing factor to cardiovascular disease in addition to physical environment. So for the remainder of the talk, I want to go through so what are the mechanisms. I think that's the kind of that's probably going through the minds of us and most of us actually. So what is actually, we've seen all this association from big data. So what does that mean and how does that work? Is there ways to implement our knowledge from the understanding of the mechanisms to improve the actual outcomes in the clinical population? This is actually work in progress. Not much has been actually validated yet. I think there's still a lot of research going on. However, based on I'm mainly basing on the scientific statement from the HA, the main categories of the mechanisms behind this association are threefold. One is psychological, second is behavioral, and third is biological. This is a nice pictogram of that kind of complex interplay of these factors. So I want to kind of go through. This is the life course at the bottom, so it's a one directional. On one hand, we have this kind of basic demographic profile or socioeconomic profile, such as education, occupation, income, and things like that, and race, gender that we cannot really change. And then on the other side, we're trying to predict and we're trying to understand how this gets down to health outcomes, such as disease outcomes, disease onset, or dysfunction of any certain condition. And then we also have talked about this environmental and then resources of neighborhoods or social context. So the first mechanism is focusing on the psychological influences. What's going on is that well-established data in psychology has shown that individuals with low socioeconomic status of racial, ethnic minorities, or low social capital, or living in an adverse environment are more likely to have depression and emotional distress. I think that's kind of, I'm not going to show data, but that we already know from our experience in the clinical medicine, as well as it's in the literature, has been validated a lot in psychology. And the poor social support and living in poor built environment also contributes to negative psychological states. If you think about it, living in a poor environment that are not supportive emotionally as well as kind of physically, that can be conducive to having more, that's not as conducive to having a healthy psychological state. So that's also kind of understandable. And then we also know from our cardiology and behavioral cardiology literature that psychological distress and symptoms such as depression and anxiety have been shown very strongly to be associated with the cardiovascular disease. This is one of the meta-analyses looking at depression and the cardiovascular disease. This is, again, very, very large study. Any comer depression was associated with a 60% increase in the instance of cardiovascular disease events, whereas the symptom itself, without any clinical diagnosis, was still associated with a 50% increase. But if you have actually clinically diagnosed depression, then you have a 2.6 times higher risk of cardiovascular disease events in instance. Very similar finding with anxiety. When you have anxiety, there's about 26% increase in having incident adverse cardiovascular events from this meta-analysis. So the psychological mechanism is that this socioeconomic status, race, gender, or in more stressful environment, whether physically or emotionally, are influencing the psychological system to be distressed, and that can lead to further downstream effects, such as not doing healthy behaviors, or not taking medications, or not following with the doctors, and that which will also have further downstream effects, as we're going to talk about. So the second the pillar of the proposed mechanisms in the social determinants of health is the behavioral mechanism. So both the environment and as well as the psychological states can have influence on the behavioral components of cardiovascular health. If you think about it, people who have poor or lower socioeconomic status tend to have increased prevalence of unhealthy behaviors, smoking, inactivity, obesity, unhealthy diet, medication non-compliance. This is actual data looking at in one of the cohorts in the health and retirement study. If you live in the lowest category of the if you have the lowest category of socioeconomic status, the odds of having current smoking or alcohol consumption, severe alcohol consumption, or physical inactivity is a lot significantly greater. So once you have unhealthy behaviors, it's guaranteed that you're going to have more risk factor for cardiovascular events, as well as you're going to have actual events down the line. Secondly, as we talked about a lot so far already this time, the environment has effects on the health behaviors too. It's kind of interesting study, small quasi-experimental study from Tennessee. They were revamping one of the regions in the Knoxville, Tennessee. So they decided to build a trail. And they did a kind of interesting study. They're counting physical activity by visual eyes for 2 hours per day. I don't know the exact details how actually they counted it, but they were counting both the walking, cycling for 2 hours per day, and they also had a control region. So this is 2005 is before the construction of the trail, and 2007 is after the construction of the trail. And then there's a significant increase in the physical activity that were observed by the observers, whereas in the control, there was none. So the change in environment seems to exert some effect on the actual behavioral patterns of the residents for living in that neighborhood, so that you can see that the neighborhood itself or its environment itself can have effect on the health behaviors as well. So the final component of the mechanism that are proposed is the biological mechanisms, which I think is kind of the most important of the three. This pictogram doesn't have the biological mechanism, so I think it's a combination of these two. So one is that it's obvious that we talked about the socioeconomic gradients. Poor socioeconomic status can lead to poor, unhealthy behaviors, which down the line can lead to risk factors and actual events, such as framing and risk factors. The second concept is more recently developed idea of allostatic load. So what is allostatic load? So this pictogram picture shows that our homeostatic system. Our body is designed such that when there is alteration of the homeostasis, we try to recover or restore that homeostasis by certain response mechanisms, such as sympathetic nervous system or HPA axis activation. That change in homeostasis is allostasis. Normal response is that after responding to that stress, that we should be able to come back to the normal homeostasis, and we should be back to this level. But if you keep giving this or getting this excessive repetitive stimuli over time, over the lifespan, then there's a point that there's going to be chronic elevation of these allostatic hormones, and that overall chronic elevation of the allostatic hormone level is defined as allostatic load. So you're just chronically stressed, and therefore you're living in a chronically stressed level as a human being, and that leads to chronic elevation of this maladaptive response system that leads to prolonged inflammatory state, vascular injury, prothrombotic state, as well as atherosclerosis. That is allostatic load. So how do you measure allostatic load? In the practicality, it's basically coming down to measuring different domains of physiologic system and then looking for aberrations of biomarkers. For example, in this study, this is a study of mites. Forgot the actual name. It's of 1,000 people. They were looking at 7 different physiologic organ systems, and they were measuring 24 biomarkers, and they were looking at the numbers of these biomarkers. For example, blood pressure, urine epinephrine, norepinephrine, heart rate variability, CRP, IL-6, fibrinogen, and there are a lot of things they measured. And you can get a sum score of this allostatic load to capture how stressed or how chronically stressed you are as an individual person. And you can see that this is basically looking at the based on the socioeconomic status spectrum, looking at different stages of life, what the allostatic load means. And if you live in the more disadvantaged, this is backward compared to other studies, the higher the worse, there is increase in the allostatic load. So the idea is that, you know, if you have a socioeconomic disadvantage or live in a harsh environment, and you're going to have chronically elevated state of these allostatic mechanism, thus leading to allostatic load, and that will eventually lead to aging of the vascular system as well as the actual clinical ACVD events and leading to poor outcomes. So this is the overall current proposed schematic of the understanding behind the social determinants of health and the cardiovascular disease. As a final slide, I want to talk about, so how do we use this information? I think that's probably the most pertinent to clinicians like us. You know, where are we in terms of, you know, how to incorporate this into our practice? Even if it's not clinical medicine, how do you even actually take this to a larger level, like societal level, to implement so that we can improve based upon the knowledge we have gained so far? So unfortunately, many questions remain unanswered. A lot of data is still very lacking. There was a recent editorial from JAMA Cardiology by Dr. Hwan and Maddox in kind of theorizing how we can potentially think about to use this information to improve the outcomes of our patients. So this is actually gradation. On the left-hand side, this is a minimalist. On the right-hand side is the expansionist that do everything. So let's start from the left-hand side. So this is about minimal additional data collection. So for example, we can collect maybe in terms of food access or availability of the transportation to get to doctors, things like that. Or maybe it's just income. It's not decided, but you know, this one more point of getting information may be or may not be beneficial. There's controversy in terms of adding more burden to clinicians to collect more data that are not purely biomedical scientific, because we're already burdened by the volume of patients, and we're always chased by time. So whether systematic implementation, recommendation by guidelines to actually collect more data on all the patients they receive is still controversial, but that is the minimalist approach. And there's some data that's showing that when we add this kind of information to, for example, framing and risk scores, that the overall risk prediction becomes better. So there may be some more research coming down the line to kind of argue for this. The second line is that performance assessment. So as we all know, that these days that we are assessed by our outcome metrics in terms of the outcomes, like, you know, readmission, mortality after transplant, things like that. And we're always affected by that. Inherently, for example, Grady or other hospitals that are taking care of people who are more disadvantaged than other people are bound to have worse outcomes. We were seeing that from all the slides that I showed you, that people living in disadvantaged areas or disadvantaged environment will have poor outcomes. But there's no good system right now to avoid penalization based on this unavoidable fact. So maybe trying to develop the systematic ways to avoid that will be helpful to increase or encourage clinicians to use this information down the line. And the third is, and maybe we should just get all the information because that seems to help. But then there's also arguments saying that maybe it should not be done doctors. Maybe it should be done by someone who's really dedicated to kind of say social work and working as a team with the physicians instead of actually physicians taking the individual steps of taking down the information about where you live and how much income you have, how much education you have. And then finally, this is more kind of, you know, what we usually think of when we think about societal changes. Public policies, you know, can we improve the transportation? Can we improve education in certain areas? Can we improve access to healthcare? And can we try to help people who have no income that probably needs any basic support? It's all very political debate and controversy that needs to be discussed not only within the clinical medicine arena, but probably is more so in the societal level. That seems to be important. I'm not gonna go through a summary given the time. So I wanna thank my mentors. My interest in this has grown over the research fellowship, working with Dr. Kayumi, Dr. Vaccarino, Dr. Sperling, as well as some people from epidemiology, Dr. Lewis, and Dr. Herman Taylor from Morehouse. With that, thank you for your attention. I'm happy to take any questions.
Great. First of all, amazing summary. This is a really, really important area. We don't think about this often in our, daily clinical activities, as you pointed out, but this is very real, and the disparities in health and healthcare play out greatest in our own backyard. And so we see this disparity greatest in,
Right.
in cardiovascular diseases. And there was a great editorial in the AJC a few weeks ago by Rich Besser, who was former director of the CDC, and Shirley Franklin, who was the mayor of Atlanta. And they wrote an editorial called The Tale of Two Neighborhoods, showing that the average life expectancy in an area that is, the distance is 5.7 miles apart in our city, but an area called Maddox Park, where people live to age 64, compared to Buckhead, where they live to 84. And so your last couple of slides are the keys for the, the fellows and our faculty to say, how do we start thinking about this? Because if we ignore it, this is very costly on a human level, but it's very costly on a healthcare economic level. And although we can say, we're in this hospital and it doesn't impact us as much, it actually does in a very big way. So I would challenge everybody at whatever level you are to A, be aware, B, read up on this and say how can each of us begin to do something, whether it's on an individual level, systems level, in terms of, like you said, other countries factor this into their risk equations, and we don't in the U.S. Other countries invest more in the other elements of care, and we unfortunately, don't. But really, really important stuff, and I'm glad you've taken this on.
Thank you.
I would echo what Larry's saying. I think it's a superb job of looking at the literature and coming to some conclusions about it. Clearly, we need to do this, and I think we need to do it on a system level. It's hard to get movement on it. We've tried several different ways of trying to get movement on it, and it's just something that's not coming to the forefront, and yet it should. One other thing I've seen is interest is you look at the neighborhoods different. I think somebody ought to look at family differences, and you go and look at how families are structured. You now have a lot of healthcare providers that have to live with their elderly parents. You have people coming home, lost their job, and coming back. And all these add factors that contribute to what you had here. But nobody looks at that, they look at the neighborhood. But I'm saying look at it even a smaller parcel. That is, what is a family and how it stresses it.
So there's, I didn't show because interest time, there's actually a big area that's, again, recently gained interest is social support and social context. That's just in and of itself is a big one discrete area of this social epidemiology. And there's data saying that increased social support seems to have a positive influence on the actual outcomes. So I think you're right that this kind of not the regional level, but more kind of family context or the context of social system is also important.
But you go into some of these neighborhoods and you've got multiple different family structures. The neighborhood is not all the same.
Right,
Some
exactly.
places it is, but often it's very
Right, exactly.
Time may be up, and Mike is not on. Have you done any work on figuring out the social interaction? It's changed so much, and that really neighborhood social interaction on the personal level, obviously, has gone way down. Everybody's online. The whole social interaction is, people don't even know who their neighbors are, and yet they have this huge. Is there any way, have you started getting into?
So I think that I haven't actually seen directly addressing that that distinction, but I agree with you that now there is a social scene is changing. But I think we can partially answer that question by differentiating between physical neighborhood environment versus social environment. Even if we're online, that we feel supported by our peers, family, as we connect with our social system. So I think it's going back to Dr. Moore's point that I think this kind of small social network social system is important to study, especially in this context, not just physical built environment. I think that hopefully will answer that difficulty of assessing who's your neighbors actually versus actually who's your physical versus real supportive neighbors that you're living with.
I guess I have, it's interesting when you look at you went through a ton of data and you look at different studies sort of pick up on different kinds of signals of what some of the big drivers of outcomes might be, and in different contexts, one thing looks like it's a bigger deal than others. Other than a probably pretty clear message that probably spending more money on the healthcare system is probably not the right answer for this. What do you think, if you had to sort of synthesize this data into one thing, where would you put the biggest pot of money? What do you think the biggest
Personally, I actually have personal views about this because I've been doing research on this during my 2 years, and then it makes me think about what is actually going on. Like I think is eventually comes down to education that provides not only the actual needs at the time, but also the means for people to climb up and down social ladders, and then also increase awareness of that we deserve same rights to receive appropriate care, and you have the opportunity to get the care if you are educated. I mean, people think about it, when think about someone who's not compliant with medication, they're rational in their mind, that they're thinking through why they shouldn't take medications that doctors prescribe that we think is very beneficial in terms of the health effects, but they're rationalizing in their own sense that they probably don't have to take the medications. And I think that's just one example of education in a small habit or small behavior, but in a larger sense that education is kind of key to provide letters to increase income, increase access to care, increase access to any research that we just talked about for the past hour. So I think that education is probably the most important in my mind, which actually requires more investment than just spending dollars. That just is more difficult. Thank you.
The preceding program is copyrighted by Emory University.